Yeah, good afternoon. Welcome to this session with a wonderful name and what can be learned from machines. I'm Katja Verhamme. I'm associate professor of use and analysis of observational data from Department of Medical Informatics, Rotterdam, the Netherlands, and I'm co-chairing.
Jeremy Rassin from Etienne in New York.
Yeah. So we have six great talks, each talk 10 minutes and then 5 minutes for discussion. I trained as a pharmacoepidemiologist, perhaps, and so I can ask the more, and medical doctor, so I can ask the more clinical questions, and then hopefully with your background, Jeremy, you'll be able to cover. Okay, so the first speaker is, I'll take my glasses, John Tazzari, going to talk about opportunities and challenges surrounding the incorporation of lab test results information within high-dimensional confounder adjustment procedures. The floor is yours.
While John is getting set up, I'll pass around some gummies because it's just after lunch and it's the last day.
Ah. Is it working?
I don't have the presentations. Sorry.
How you doing? No worries.
I was about to do Canadian local jokes, but no, I don't have any. I mean, I do, but I've heard jokes. It's all you.
Great, thanks. Good afternoon. Yeah, I'm really grateful to have this opportunity to present our work surrounding the opportunities and challenges of incorporating lab test result information within high-dimensional confounder adjustment strategies, and to the following team listed for their contribution to the work. Here's our COIs. So, the HDPS algorithm aims to optimize confounding capture and control in a given setting, and it's become an established method in this field with a variety of evidence highlighting the potential benefit across both administrative claims and electronic health record databases. And whilst the HDPS traditionally leverages the presence or absence of codes recorded in these databases, this doesn't preclude the inclusion of additional data types. So, for example, Rassin and colleagues have investigated the incorporation of free text notes within the HDPS. However, it's really important to consider when we're using this sort of non-coded information, there are often going to be these additional considerations, so around data quality and processing. One example that we have available in the UK electronic health record setting surrounds lab test result information. And whilst theoretically this is possible to include within semi-automated confounder adjustment approaches, there are sort of these common concerns around missing data, data quality, which has meant that these data are currently underutilized, I think, in HDPS strategies. So throughout this talk, I'll be referring to specific features of the HDPS algorithm, and I'll just basically outline the generic steps here. So if we sort of assume we have a set of investigator-specified covariates, we could then supplement them, firstly by specifying a number of data dimensions containing pre-exposure features and maybe separated by different aspects of care within the system that we're studying. And in step 2, we might assess the prevalence, so filter based on the top number of most prevalent codes or features within each dimension. In step 3, we're going to assess the feature recurrence. So for each patient, we might define up to 3 HDPS covariates for each of those features based on the frequency of recording in a covariate assessment period. And the traditional cutoffs are listed on the slide, so I won't go into that. After step 3, we've got this huge battery of covariates, and in some settings this can be sort of thousands. So we need to kind of subset them and prioritize and rank which ones are important. And in step 4, there's sort of various options in how we can do this. So traditionally it's the PROS formula, but there are also sort of exposure-based flavors and machine learning approaches too. And then finally, based on these rankings, we might select a number to augment our investigator-selected set of covariates. So this project, incorporating test data within the HDPS framework, was motivated by a recent study And I'll just briefly recap some details and findings from this. So we conducted a cohort study investigating the use of PPIs and the risk of all-cause and cause-specific mortality. This was based in the UK CPRD Gold database, and the primary comparison was made between PPI and H2RA users. The analysis strategy consisted of propensity score and HDPS weighted using ATT weight in Cox regression models. And overall, the sort of pattern results highlighted many outcomes where PPI use was associated with an increased risk of cause-specific mortality. But these associations are generally absent in within-person designs and randomized trials. So the overall conclusion was that residual confounding remained a major concern despite adjustment for the HDPS using clinical referral and prescription information. So in this project, we reanalyzed the COPD-specific mortality outcome using an approach that we have described before for applying HDPS in UK EHR data. We chose this outcome since we observed an increased risk associated with PPI use that we hypothesized was likely non-causal based on disease pathogenesis. And the HDPS design choices for this analysis are sort of displayed on the bottom left-hand side there. So in brackets, we've got the coding system, and we've captured information surrounding clinical referral and prescriptions. So in step 2, we chose the 200 most prevalent codes, and we ranked and prioritized using the BROS formula and selected 500 to augment our analysis. The results are presented in the bottom right-hand side of the slide, and reassuringly, we observed good consistency between the original and this reanalysis. And this was sort of fairly robust to the number of HDPS covariates chosen. So moving on to then incorporating lab test information. In this case, we considered both information on requested tests and continuous test values themselves. So by tests requested, I'm referring to codes in UK EHRs which indicate a test was requested and conducted in primary care, regardless of the actual result itself. And since in CPRD Gold, these are identifiable using distinct read codes, there's actually very little processing required of this data to incorporate it into the HDPS. We can simply just add an additional data dimension capturing the test requested in the covariate assessment period, and then basically proceed as we would normally do. Now, where it gets more complicated is when we're trying to actually incorporate the continuous test results themselves. And in this initial application, we therefore restricted focus to 35 common blood test results that we had available in our data. So briefly, the way we get these as researchers, there's no prior cleaning before these data are delivered. Therefore, the raw data themselves contain implausible values and multiple units of measurement which need to be harmonized. And we used previously developed clinical therapeutic cutoffs to define plausible values and sensible therapeutic ranges for these values. And the panel on the right just highlights the extent of these challenges and shows the distribution of calcium measurements on the left-hand side before cleaning, and then after, on the right-hand side, we've cleaned these results, and we can see that there's a much more sort of sensible pattern of values. So how do we incorporate these into the HDPS itself? So in step 1, we included an additional data dimension which contained for each patient the most recent cleaned test result value for each test available. Now in step 2, because we only considered 35 tests, we didn't actually filter by the prevalence, but I sort of imagine a proposal where we could filter by a threshold, for example, based on the percentage of missing data in the test values that we have available. In step 3, we assessed a patient's test results against this therapeutic range and created up to 3 binary covariates based on the value relative to that therapeutic range. So here we've got low if the test value was below the therapeutic range, normal if it was within, and high if it was above. So again, this then creates more binary covariates which were added to that existing pool that you would get normally, and we ranked by the BROS formula as usual. But motivated by the sort of disadvantage that we're obviously dichotomizing continuous variables, and that reduces statistical power and potentially doesn't fully remove confounding bias. For any test cutoff covariate that was selected in the top 100 across all of the data dimensions, the corresponding continuous variable was included as a linear term alongside a missing indicator in the HDPS model itself. So here are the results. And compared to the HDPS approach, not including test information, we observed a modest reduction in the HR towards the expected null association. And now, obviously, because we're increasing the pool of candidate variables, it might be necessary to actually include more than 500, but future work might sort of look into this. And in sensitivity analyses on the right-hand side, the results were fairly consistent when extending the covariate assessment period from 1 year back to 2 years. So a slightly surprising finding really was that 46% of the top 500 covariates selected were derived from these test-related data dimensions that we've added. And these are displayed in the yellow and blue points on the figure on the right-hand side. And the figure shows the univariable confounder exposure and confounder outcome relationships for the HDPS covariates included, with some variables from the test dimensions having sort of fairly strong associations with both exposure and the outcome. So in terms of conclusions, the high proportion of test-derived covariates selected for the HDPS, I think really does highlight the potential importance of these data for mitigating confounding bias in UK EHRs more generally. And we've just demonstrated how relatively simple methods can be used to incorporate these within the HDPS framework, whilst being consistent with the semi-automated nature of the approach generally. In terms of sort of future directions for this work, I'm really interested in exploring how we might look at semi-automated sort of flexible modeling of the continuous variables, so for example, splines and fractional polynomials. I'm also interested in looking at plasmode simulations to investigate the properties of these proposed approaches. And it might be really interesting to actually compare what we've proposed against alternative proposals for incorporating these sort of values. So I noted the Harris and Platt paper that's been released, that was published recently. And then finally, I just think there's a sort of broader point that investigating the implications surrounding missing data methods in the sort of HDPS concepts, I think, is quite a sort of under-researched area. So, yeah, in conclusion, whilst the test information modestly improved the adjustment for confounding in this setting, I think HDPS is always limited no matter what the setting and the data that you throw at it by the data provided and available. So it's always possible that key concepts and proxies are not retrievable from what we give it. But thank you for listening, and I'll take any questions.
Thank you, John, for a great talk. I think we have time for 2 questions.
Holly from Daiichi Sankyo. Yeah, thank you for excellent presentation. I have one question. So for the diagnosis code, do you use ICD-10 or the risk code?
Yeah. So we've sort of already done some work where we were really considering how the principles of the HDPS as proposed in claims data applies to our work in UK EHR data. And so, yeah, in the clinical data, we have sort of mapped this to ICD-10 to sort of give us what we believe are more interpretable proxy covariates. And the sort of full details are described in this paper in the top right-hand side.
Yeah, so I have a question because HDPS work on the base of broad formula and also prevalence of comorbidity or the lab or whatever. If you use this, the ICD-10 code, it's too granular, that's why prevalence low, and when prioritize, maybe it is the most lab appear like 46%, but not like
so just
diagnosis or whatever.
Yeah, so just to clarify, the test results information is not based on ICD-10 codes. They are discrete on read. In terms of the granularity point, I think that is something that's been explored more generally in the HDPS, whether looking at 4-digit versus 3-digit ICD-10 makes a huge difference. I can't really talk to that in the UK setting, but I think that's definitely something that we could look at in the future as to whether or not that granularity makes a meaningful difference in terms of what the HDPS is able to do based on like the performance.
Well, as the slide says in huge letters, thank you. Thank you, John. Thank you for your questions. We'll now move on to the next. And if you can get set up, we will now. Sorry? Okay, so our next talk will be comparison of stable balancing weights versus propensity score weighting for RWE or external clinical study comparison arms to single arm clinical trials. And we have Stephen Johnston here speaking on this August topic.
All right, thank you. Thanks everybody for coming today. I'm Stephen Johnston, and I'm on the medtech side of the Global Epidemiology Organization at Johnson & Johnson. And today, as Jeremy just said, I'm going to be presenting on a relatively newer method called stable balancing weights in comparison with propensity score weighting for establishing external control arms when comparing against single arm clinical trials. So this is our disclosure. And I'd like to acknowledge this method is really the brainchild of Professor Jose Zubizarreta from Harvard University. The original paper was published in 2015, and we've been working with him to implement these methods within our applied research that we do in GEO at J&J. So in terms of just level setting on indirect comparisons. So indirect comparisons seek to compare two treatments, let's say A and B, that are not studied within the same study. And there's really kind of two major flavors of that. You've got the anchored comparison, which involves a common comparator between two randomized trials, and then you have unanchored comparisons, which involve two separate single-arm trials or an external control arm. And with medical devices, these are often studied in single-arm clinical trials lacking a comparator. So for us, most indirect comparisons of devices will be involving an unanchored comparison. The problem with unanchored comparisons is they lack that common control arm, and therefore any differences in the underlying populations between treatments A and B could be potentially biased because of the differences in the population. So when you're doing an unanchored comparison, the main goal is that you want to weight or match A such that it mimics the group in B. There's another additional consideration, which is access to individual patient data. You can see on the left-hand side, it's depicted that we have a data set for treatment A and we have a data set for treatment B, and that sets us up to really be able to do whatever kind of traditional statistical analysis we want. And that's called full IPD. But it can also be the case that you only have access to one data set. So let's say in this case here, we've got access to our own data for A, and then we've got a published table 1 in a manuscript, and we need to figure out how to weight A such that it looks like the marginal distribution of B in the manuscript. There's a lot of other considerations that you have to take into account when doing indirect comparisons. It's kind of beyond the scope of the talk today, but I wanted to show how you can use stable balancing weights to achieve this part of making A mimic B. There's a number of different methods that can be used. There's matching methods, there's weighting methods. I'm talking today about these optimization-based methods, but suffice it to say that in practice, indirect comparisons have typically been accomplished through some form of propensity score weighting in the past. So there are some potential issues with propensity score weighting. First of all, extreme weights can often happen, and that can necessitate trimming, which results in sample size loss. There's also this notion of the effective sample size. So whenever you apply a weight, it reduces the precision of your estimates, and it makes it such that your actual sample size is not effectively equal to what it looks like. So the definition of the effective sample size is that it's the equivalent size of an unweighted sample that contains the same precision as the weighted sample, and this is a function of the variance of the weights. So if you have extreme weights, high variance, that means lower effective sample size. In the cases with small samples, regression-based, like maximum likelihood techniques for propensity score estimation can also have problems. I mean, sometimes if you're in the real case of rare exposure, the case of rare exposures, you can have limited degrees of freedom. You can have few treated patients per covariate, and you can also sometimes have issues with model convergence. So enter stable balancing weights. Again, this is Jose Zubizarreta's creation, and it was designed to address these problems. So this is an optimization-based technique. And with optimization problems, you have two things. You've got an objective function, that's what you're trying to achieve, and you have constraints. So there's the constraints that you're subject to when trying to achieve your objective. So the objective of stable balancing weights is to generate the weights of minimum variance for the units that are to be weighted, oftentimes the control if you're trying to do like the ATT. The constraint is that pre-specified balance criteria, usually standardized mean differences, for the weighting covariates are met. And you can apply constraints for each covariate separately. So if I have a covariate that's highly prognostic, like let's say cancer stage, I can say that I want to standardized mean difference of 0 for that one. Then I can say, diabetes, I want a standardized mean difference of 0.1, and then I can say region, maybe it's not important, I'll have a standardized mean difference of 0.25. So it's highly flexible. And so what happens is, once you run the optimization problem, it yields the mathematically guaranteed largest weighted sample, that is the weights of minimum variance, subject to your user-specified constraints. So this is called the optimality guarantee. The way in which you implement it, it's done in R. So the first step is you choose your estimand. So that could be the ATT, the ATC, ATE, or you can actually specify any marginal distribution of covariates that you want your weighted sample to look like. Sometimes it doesn't work out, but you can attempt it. Then you choose your balance constraints for your covariates. So maybe you just want to say everything has to have a standardized mean difference threshold of 0.1, because that's like the common cutoff. But again, you can apply different standardized mean differences for each variable. Then stable balancing weights will generate the weights, and by definition, the balance constraints will be met for the weighted sample. And then you perform your effect estimation. So you use the weight like a propensity score weight, let's say in a generalized linear model. So here's an applied example. The objective here was to compare the performance of stable balancing weights with that of inverse propensity weighting for creating an external control arm to a clinical trial using real-world data. We compared the methods on post-weighting effective sample size and the distribution of standardized mean differences of covariates between the treated and control groups. We had 5,333 patients from a historical database cohort, and we weighted them to mimic 167 patients from a single arm trial that we had. Right now, we had access to the individual patient data in both cases, but you don't need full IPD for SBW. You can literally just use stable balancing weights to reweight your sample without having the data from the other cohorts. So that's kind of a cool feature of it. We weighted on 10 different variables that had 18 levels that were common between the trial and the control cohorts. We implemented stable balancing weights to weight to the ATT, and we use something called a grid search, which basically you enter a series of standardized mean difference values that get progressively larger, and the algorithm will find the lowest standardized mean difference threshold at which the optimization problem can be solved, and this favors obviously balance over sample size. In this case, the optimization problem could be solved at a standardized mean difference threshold of 0.002, which is like really, really low. But we wanted to see how low we could get there. For the inverse propensity score weighting, we just used the traditional methods of implementing it via logistic regression without trimming, and again, the ATT estimand. So I don't know how easy it is to see this in the back for you guys, but here we have a table that shows the various covariates on which we matched. We've got the treated cohort, 167 patients, our control, 5,333. And before weighting, there was substantial imbalances between the groups on the weighting variables. We had an average standardized mean difference value of 0.35 and a range from 0.01 to up to 2.35, which is quite high. This is the results after weighting. So if you direct your attention to the red column, first of all, this is the stable balancing weighting results. You can see that all the standardized mean differences are at that threshold of 0.002 or below. We have an estimated sample size of 1,882. Now, for the inverse propensity weighting, it did pretty good. All of these standardized mean differences are below nothing's above 0.09. So by the normal standards of weighting and balance, it did pretty well. But it didn't do as well as stable balancing weights, and it has an estimated sample size of 1,633, so more than 200 fewer patients than stable balancing weights. I had mentioned earlier about the flexibility of applying your standardized mean difference constraints. This is from another paper that we published in which we were looking at two different devices in the context of a nephrectomy, and laterality was something that we thought was really important, so we set our threshold for standardized mean differences at 0 for laterality, and then we let the other ones kind of go using the grid search there. But it just illustrates that flexibility. So in terms of takeaways, there are some limitations, obviously. This is a newer method. It's still gaining traction. They're often, new methods are often viewed with skepticism, and regulatory bodies could prefer propensity score methods. There's at least one statistical guidance document that the FDA is involved with where these optimization methods made it into the appendix, so we're making progress. But anyhow, you have to take that in consideration. It's also not for stratification if you want to use that method. And there's still a bias variance trade-off, so you do still have to tinker a little bit. You might want to look at multiple different balance criteria and see, how much more sample size you can gain by relaxing your standardized mean difference criteria. The key benefits, again, it provides an optimality guarantee for the largest sample. There are user-specified target estimates. You don't have to estimate a propensity score. It directly targets balance through optimization. It's compatible with the partial individual patient data, and the last point I've kind of beaten like a dead horse. So in conclusion, in this example, and several other examples that I haven't presented but that we've seen in our research, stable balancing weights outperformed inverse propensity weighting on effective sample size and overall covariate balancing, and we view it as a promising and flexible method for establishing weighted external comparison arms for single-arm trials with or without individual patient data. Thank you.
The floor is open for questions.
Hello. Thanks for the interesting presentation.
Sure.
I'm wondering, with the propensity score method, I think in the HEO world, it's called matching adjusted indirect comparison.
Right.
You didn't trim, right? So I wonder if you did trim, would that, that probably should increase your effective sample size a little bit and I guess protect against extreme weights, which could, I'm wondering if you tried trimming, do you think you would get some improvement and maybe they'd be more comparable?
Yeah, I think with trimming, it would be a little bit ambiguous, right? Because when you trim, you're going to lose some of your sample,
Right.
but the variance will go down, so it's a little hard to tell. That is something we should try. We've used generalized boosted modeling versus stable balancing weights, and that really tries to minimize the variance as well, but through sort of a different way. And stable balancing weights outperformed it in that scenario, but I didn't try that, so I can't tell you exactly, but that's something we should test.
Okay, and one other quick question is
Sure.
that you had access to IPD for both, right? I wonder how the results, did you try actually combining the IPD and seeing, if you directly adjusted for covariates with the IPD, how that result would compare?
Yeah, so with stable balancing weights, whether or not you get the exact same result, whether you're using IPD on both sides or just the one side. So it's really interesting. It will just optimize to any possible pre-specified estimand.
Okay.
So it doesn't make a difference, which is kind of neat.
Okay.
Yeah.
Thank you.
You're welcome.
Time for one more question. I have one, which
Sure.
I'm curious on slide 12. I think it's slide 12. The weighting of the variables post-weighting, I think it's called. Yeah. On the SBW control, the red numbers, it's
Yeah.
either 0 or 0.002.
Right.
And I'm curious sort of why that is. Is that like a numerics thing or so what's going on versus the much more heterogeneity in the blue numbers?
Yeah, so what will happen is once it picks that threshold through the grid search, that is the maximum standardized mean difference to which the optimization algorithm will attempt to get balance. So 0.02 is sort of the limit, but it will also allow it to get lower than that. So those 0.00s they should probably have like less than 0.001 or something like that. But that's essentially what's going on. And that's also another important part. Like if you set the threshold at 0.1, it will only try as hard as getting to 0.1. So you might get a much larger sample size, but you might be doing yourself a disservice because you can do a lot better without necessarily a lot of effective sample size loss for a much lower threshold.
Okay.
So it does require tinkering. Yeah.
Interesting. Well, thank you very much.
Thank you.
We can move to the third speaker, and that's Yuli. I hope I pronounce it correctly. You're going to talk about standardization over disease risk score versus propensity score for confounding control when using random forest for model fitting.
Which is sorry, I was trying to get this up here.
you so much. Hello, everyone. I'm Yi. I'm a third-year PhD student in epidemiology. So my presentation is on standardization over disease risk score and propensity score for confounding control using random forests for model fitting. So for the disclosure, Robert Plass has been serving as a consultant and a speaker for Biogen, Boehringer Ingelheim, Merck, and Pfizer. And Kazuki is a medical director at Takeda Pharmaceutical Company. And so first, I will talk briefly about two confounding summarizing scores, propensity score and prognostic score. So we all know the seminal PS paper by Rosenbaum and Rubin, but prognostic score as the analog of PS, or in pharmacoepi, we call it DRS, is less known. DRS is first proposed and formalized by Hansen. Similar to PS, where we deal with the treatment confounder edge, DRS works with the confounder outcome edge. Since PS is commonly used, I will just give a fast review. So there are two main assumptions of using PS. So the first assumption is that treatment A is unassociated with confounder C when conditioning on PS. And the second assumption is if counterfactuals of Y are unassociated with A when conditioning on C, then they are also independent of A when conditioning on the PS. Then when assuming positivity and consistency hold, we can get the formula for ATE using Robbins G formula. Although DRS is the analog of PS, there is some key difference. DRS describes the baseline risk of the outcome had the treatment intervention not happened. So DRS models probability of PY sub 0, the counterfactual if the subject had not been treated. So PY is the final outcome, and it contains the effect of the treatment. And so DRS should not contain the treatment's information. So Y sub 0 is independent of C given DRS. And since DRS is about counterfactual had the treatment not happened, the DRS balance can be checked in the control group only. Then how about Y sub 1? Since we need both counterfactuals to get the ATE formula. So when modeling Y sub 1, we need to think about if treatment effect is the same for treated and control groups. When there is modifier M, then the assumption for Y sub 1 holds when we condition on both DRS and M. The confounding assumption for Y sub 0 is the same as the one in PS. And if there is no M, this also holds for Y sub 1. The critical assumption of using DRS, but not stated by Hansen, is that if there is M, then what can the confounding assumption be? It's not hard to infer from the previous assumptions that when conditioning on both DRS and M, Y sub 1 is unassociated with A. Then using G formula, we can estimate ATE similar to what we do when using PS. So far, we have seen that DRS focuses more on the control group. Then the natural question is, in which population should we fit DRS? Or should the treatment group contribute to DRS estimation? So the first conventional approach is to use the control subcohort to fit DRS, then impute the treatment cohort. So this approach has the issue of the overfitting, as the balance can be checked in the same control group only. And the second conventional approach is to use the full cohort. But this one needs the correct specification of M. If we don't know which variables are modifiers, but just the control for the main effects, then the estimated DRS may carry information for the treatment effect. And these two methods are called same sample methods. And in Hansen's paper, he suggested that we use a separate control cohort to fit DRS, then estimate DRS in the main study cohort, then controlling for M in the outcome model. Now let's look at a simple simulation. We will use the separate cohort method for DRS. So in the true DAG, C1 and C2 are the true confounders. C3 and C4 are just causing the outcome. So the study population is generated like this. We can see that the true outcome model has the qubit term and also the three-way product term for C1, C2, and also C4. And C1 and C2 are the two M's here. So now we will compare the PS and DRS methods. For PS, in the first model, we use C1 and C2 to predict DRS, and in the outcome model, we can suppose that we know C1 and C2 are the modifiers. And in the second method, suppose we don't know C1 and C2 are the M's, so we only control for PS and C3 and C4. In the third model, still suppose we don't know C1 and C4 are the two M's, but we are concerned about there can be some M. So we try to control for the product term for the treatment and also the PS. So for DRS, we can do the same things. Since the true DGP is quite complicated, it's preferred to use the non-parametric methods. So random forest is commonly used in PS, and it's an ensemble tree learning method. So for PS and DRS, we fit RF for both scoring and also the Y models. And to show how they perform, we will also compare to the parametric ones. So to make the comparison fair, we still suppose that we know the true M's are C1 and also C4. So this figure shows the RD estimates from all the models, and the gray line is the ground truth. So we can see that the three PS methods using RF and also the DRS methods, when we correctly specify C1 and C4, give the consistent estimates. When we don't control for C1 and C4 or try to adjust for the product term for treatment and also the DRS, then the RD estimates can be quite inconsistent. And so the red and the pink ones are using the parametric models. So just to wrap up, here are the key messages. DRS can be useful for confounding control. We can think of using it when it's hard to use PS. So for future research, more work can be done in DRS. We hope to have new methods that we can fit DRS in the same study cohort. And thank you all. Yeah, that's at the end of my presentation.
For this great presentation. I don't know whether there are any questions in the audience. Do we have time for 2 questions? If not, to start with, sorry, please, yeah, go ahead.
Thank you for a lovely presentation. Can you tell me a little bit about U?
U is the unmeasured confounder.
Okay, so you have
Yeah.
that in all your analysis?
So when generating the true Y, we include you, but when using the PS and DRS, we don't control for you since it's measured. Yeah.
So they perform quite well despite the fact that there's
Yeah.
residual confounding.
Yeah.
Nice. Thank you.
Any more questions? Yeah.
Hi, Theo Stimmer, UNC. Nice presentation. You have no instruments in your simulation setup, and the instruments would obviously cause bias amplification if you include them in the propensity score. Can you explain why you didn't include instruments in the simulation setup?
Yeah, so at first we included instruments, but at the end, since we are not using the IBs to estimate an PR or the DRS solution, we just take them out.
Yes, but following the previous talk about HDPS, we would empirically often have instruments in our propensity scores or close to instruments.
So in PES model, if we have the instruments, we will not control for them when estimating PS, right?
Yes, but
Yeah,
we
yeah.
never know what instruments are. So in practice, we are often having instruments in our propensity scores or close to instruments.
I think that's a good question, and then
I mean,
I can try to
Would you expect
include
that
them in the future simulation.
Yeah, it may be an
Yeah.
additional difference between the propensity score and the disease risk score. And then you only included C1 and C2 in your propensity score. Why not C3 and C4?
Since they are only causing the outcome, and they are not confounders and not causing the treatment, so just based on this stack, we only control for C1 and C2.
But we know that including 3 and C4 would improve the performance of propensity scores.
Yeah, I think you are right. Yeah.
Yes, thank you.
That's right.
Yeah, I think I had a small question. I don't know whether, so when you check literature about what to choose between propensity scores or disease risk scores, it is stated that, for instance, disease risk scores have their place when the exposure is low. I don't know whether you applied that in your modeling, whether you checked the frequency of exposure, whether you saw better performance or.
Oh, so you mean the prevalence of the treatment in the main study cohort?
Yeah.
Yeah, so here I presented, so the prevalence of A is 0.4. It's here. It's the second bullet
Okay,
point.
so you applied that. You took that into account when you developed your model.
So when generating A and Y, the prevalence can be anything, and I just presented these
Okay.
prevalence.
Yeah. Okay, thank you. So I think we can thank you for a nice presentation, and we can move to the next speaker.
Thank you. And the next topic will be high-dimensional iterative causal forest, HDICF, a novel algorithm for subgroup identification in claims data. Presenting will be Tiansheng Wang.
Okay. Hello, everyone. I'm Tian. I'm a postdoc from UNC. As you know, average treatment effect often vary across different subgroups. And real-world evidence studies are often more inclusive and have a larger sample size than randomized trials. That offers a great opportunity to assess heterogeneous treatment effect. So I'm very excited to introduce the novel subgrouping method we developed, high-dimensional iterative causal forest for subgroup identification using real-world claim data. The disclosures. So non-parametric tree-based machine learning subgrouping method are very popular because they don't have the limitation of a traditional parametric approach, such as a model misspecification or prior knowledge of treatment and variable interactions. So a decision tree recursively partition a population into subgroups, i.e. the leaves, and minimize the difference within a subgroup and maximize the difference across different subgroups. And the random forest is a large collection of many individual trees, which works by averaging prediction of each individual tree. Both individual tree-based and random forest-based subgrouping methods are available, but none of these methods are designed for assessing causal effects or for observational data. And causal forest is an extension of random forest. The key features include assess heterogeneous treatment effect in the causal framework, and including the propensity score component, which adjusts for confounding. However, using a decision tree from causal forest for subgroup identification is not ideal either, because it's often very unstable and very deep, which means it gives us many trivial subgroups. That is not very helpful for clinical decision and providing tailored therapy for patients. So to get a stabilized and important subgroup decision, we modified the causal forest and developed iterative causal forest subgroup identification algorithm. And so on the high level, ICF iteratively grow shallow causal forests at different depths. And then from depth 2 to depth 5, at each depth, it pick the best tree that best represent heterogeneity signals from each forest. And then vote for the most stable, most popular tree structure, a subgroup decision. And then predict the causal treatment effect by building this model, including interaction terms of the treatment and the subgroup decision. And then find the cross-validated subgroup decision as that best predict the causal treatment effect. That will be the output of the ICF algorithm. So we use this empirical study to show how ICF works. The previous both randomized trials and observational studies both show that SGLT2 inhibitors had a larger treatment effect on reducing hospitalized heart failure risk in patients with existing heart failure. So this is an empirical study that we kind of know the ground truth of the treatment heterogeneity. So in this active comparator user cohort, we follow the patient from second prescription to a maximum of 2-year follow-up and assess the treatment effect by risk difference using initial to treatment analysis. So after implementing ICF, so first the causal forest identified important variables. The top few variables are shown on the right. So edema, it is a key symptom of heart failure, and followed by arrhythmia, ambulance use, and atrial fibrillation. So arrhythmia and AFib are both highly correlated with heart failure. And then by loop diuretics, which is the key treatment for heart failure, and by congestive heart failure. And the ICF identified subgroups by the following variable: edema, gender, age, and the DP4 inhibitors. So the largest treatment effect is observed in subgroup 1. So SGLT2 reduced the risk of hospitalization of heart failure by 3.9%. And comparing to other subgroups, 2 to 4, this treatment effect is obviously very large. And so we show in this empirical studies that ICF successfully identified expected subgroups. Access to a large clean database combined with ICF can give us an unprecedented opportunity to identify heterogeneous treatment effect. However, ICF still relies on predefined variables, so we may still miss important variables or poorly defined variables by using inaccurate codes. So to address this limitation, we developed high-dimensional iterative causal forest So the HD-ICF is based on high-dimensional feature and the causal forest method. So 3 key steps. Step 1 is to obtain the code from different data source, similar to HDPS, and then build a categorical variable for each code. Step 2 is to select important variables to get, to reduce the variance of subgroup decisions and from many hundred of HD features. And step 3 is just implement ICF in this selected variable X prime. And we use the same empirical studies and just focusing on ICD-10 error for simplicity. So we require patients enter cohort between October 2016 to December 2017 so that we follow them for a maximum of 2 years. And similarly assess the treatment effect by risk difference using initial to treatment analysis. So after implementing HD-ICF, so the first step, get 200 most prevalent code from 5 data dimensions, including inpatient, outpatient, diagnosis and procedure and prescriptions. And then required code prevalence is over 1%. And then build these categorical variables for each code, along with demographic info key feature, age, sex, race. So we got a total of 600 high-dimensional features. And then among those 600 variables, we select the top 10% of them, which get 60 variables. The top 5 are shown here in this table. So COC3 loop diuretics, and then followed by I-50 heart failure, and then ischemia heart disease I-25, and then 85610 prothrombin time test. Because heart failure is highly associated with atrial fibrillation, and patients with AFib are often prescribed anticoagulants to reduce the risk of blood clot and stroke. So this patient will receive the prothrombin time test, and then arrhythmia patient. And so step 3, ICF identified subgroups by these 2 key codes, loop diuretics and the prothrombin test. And the largest treatment effect is observed in this group in patients with at least 2 loop diuretics. So SGLT2 reduced the risk of hospitalized heart failure by 2.6% comparing to GLP-1 analogs. And then we also did sensitivity analysis, try different parameters of HD-ICF, one at a time, including using lower variable importance cutoff value, different number of codes from data source, and different code prevalence cutoff value, and higher granularities of ICD and ATC codes. So overall speaking, the key splitter identified by HD-ICF are consistent with primary analysis. And this analysis suggests that using 3 digits of ICD codes and the 3rd level of ATC codes, using a large number of codes from each data dimension, and the higher variable importance cutoff value are helpful for identifying expected subgroups. So I won't go to the details of this table, and I just want to highlight a serious typo error. So HD-ICF, the aim is identify subgroups, but HDPS aim is confounding control. This should be the first row should be the other way around. Yeah. So limitation of HD-ICF, so it relies on the assumption of no unmeasured confounding. So it should be applied in a robust study design, such as active comparator user design, where we can effectively reduce unmeasured confounding. And using the key confounder may not fully adjust for confounding in some scenarios. And this method also is limited by, low sensitivity of some codes in some scenarios. So we need to carefully explain the result and look at validation studies also. And further studies are needed to test this method. So in conclusion, HD-ICF is based on high-dimensional features and causal forest method. So it is the first semi-automatic machine learning subgrouping algorithm that without relying on predefined variables or prior knowledge of treatment variable interactions. And our empirical studies shows that it can successfully identify important subgroups with heterogeneous treatment effect. And HD-ICVF provides a valuable tool for detecting and assessing heterogeneous treatment effect in real-world data setting. And this work is now under review by AJE, and I acknowledge my coworkers, and thank you for your attention. And the for ICF code is available on this GitHub page. Thank you. Yeah.
The floor is open for questions. Looks like questions are literally arising. Oh, maybe not. I'm trying to put it all together, and forgive me if this is naive. So the subgroups are being built with respect to a particular outcome, right? Because you're finding cross-validated.
Oh, yeah.
So can you give a perspective on building subgroups with the outcome available to you versus building subgroups with the outcome, pocketed away somewhere or not available?
We need to define outcome first, and depend on the treatment covariates and the outcome, the confounding structure. Say for this empirical study, our outcome is 2-year risk of hospitalized heart failure. So if you have different outcomes, subgroups apparently just may vary. Yeah.
Okay.
Yes.
Hi, my name is Sam Xu. Very great presentation. I'm from University of Minnesota, PhD candidate. So go back to your next slide. I think in the exclusion criteria, you exclude ESRD and CKD stage 4 and 5. And I wonder that in your final output, have you identified CKD stage 3 as a covariate or confounding for your outcomes? Because usually in practice, CKD stage 3 is also hand in hand to heart failure. So I wonder, have you identified any association for that specific covariates for CKD stage 3?
Oh, okay. Yeah, we include the CKD stage 3. We only exclude severe renal failure patients. Yeah, I think we do observe some in the table 1 we see strong associations between CKD stage 3 and this outcome. So that's what you are stressing. There's a CKD stage 3, it's an important confounder. This one? Oh, here.
Can you?
Yeah.
Can everyone make sure to use the microphone for our?
Yeah, sorry. It's just from stage 1 to stage 3, but stage 4 and 5 renal failure patients are excluded. Yeah. Okay. Thank you. Yeah.
Hi, Cindy Gurman, Syrups Consulting. Very nice presentation. Thank you. I had a question about, the random forest techniques are very data-driven. And I know you have a test sample and a cross-validation set to cross-validate. Did you or are you thinking about trying to do this in another completely different data set and see how it works? Because even with cross-validation, it's still the same data set. It might not replicate in another data set, especially the trees. As you get down further into the trees, the sample sizes tend to get very sparse, and it really can go a lot of different ways. And so the bigger the tree, the harder it is to cross-validate. Is that the same with causal?
Yeah. Similarly, and thanks. This is a great point. So for HD-ICF, we haven't tried it in another data set, but for ICF method, we have tested in market scan data. So that empirical study is for assessing GLP-1 analogs effect on asthma exacerbation, and we identified patients with prior ER visits has more severe, more likely to have asthma exacerbation. So prior ER visit is kind of a proxy for prior asthma exacerbation. And yeah, so that's identified by ICF, and we would show that it may also work in other data sets. We will test it in HD-ICF also. And for speaking of cross-validation,
I apologize, we're out of
Yeah.
time. Thank you so
Okay,
much for the
okay.
presentation, the questions, and we'll move on to our next speaker. Thank you.
And the next speaker is Salvatore Grisapulli. He's going to talk about can machine learning approaches help accelerating rare disease diagnosis, with an example from Acromegaly.
Good afternoon, everybody. Thank you for the introduction and for the opportunity to present our research activity on the development of machine learning algorithms for the early diagnosis of acromegaly. I have no conflicts of interest to declare. So, acromegaly is an endocrine disorder characterized by an increased level of growth hormone and of insulin-like growth factor 1, which usually depends on the presence of a pituitary adenoma. It is considered a rare disease with a prevalence of less than 6 cases per 100,000 individuals, and first-line treatment includes surgery and radiotherapy, but for those patients for whom surgery fails or it is contraindicated, therapy with somatostatin analogs, dopamine agonists, or pegvisomant is recommended. As for the majority of rare diseases, also acromegaly is characterized by a considerable diagnostic delay, which is about 7-8 years, and this is mainly due to the fact that this disease usually presents with clinical manifestations and comorbidities, which are also characteristics of many other more common conditions, and so this delays the diagnosis of acromegaly. As such, the aim of our study was to develop and internally validate both traditional statistical models and machine learning algorithms for the identification of a combination of predictive variables for the early diagnosis of acromegaly using claims databases of Sicily region in southern Italy. So to achieve this goal, we used Sicilian claims databases in the period between 2011 and 2018, and we identified acromegaly cases as those patients who had claims suggestive of acromegaly in at least 2 different data sources. We applied this validated coding algorithm, which has been recently published in the literature and achieved high diagnostic performances. In particular, according to this algorithm, subjects with acromegaly were those subjects who had claims suggestive of acromegaly in 2 different data sources, including hospital discharge record databases, exemption from copayment databases, pharmacy claims database, and a database containing information on the prescription of diagnostic tests and specialist visits. To each identified case, we assigned an index date, which was defined as the date of the first occurrence of at least one acromegaly-related condition included in the algorithm, and then each identified case was matched with up to 10 controls extracted from the same data source in terms of age and sex. Controls received the same index date of their corresponding controls. So we retrospectively evaluated the database history of both cases and controls in Sicilian claims databases. So we evaluated the time between the first record in Sicilian claims databases and the index date, and we observed that the highest overlapping in terms of database history for both cases and controls was in the time frame of the 2 years prior the index date. So considering the clinical relevance of this time frame, we decided to focus our predictive analysis on this time frame. So we proceeded by exploring the combined effect of several covariates in predicting the diagnosis of acromegaly using both traditional statistical models, so the logistic regression models, both the unconditional and the conditional regression model with lasso penalty, and also using machine learning techniques, so the recursive partitioning and regression tree, the random forest, and the support vector machine. So we developed and applied our algorithm on a random portion of the initial dataset, accounting for the 70%, which is called training set, and we then evaluated the statistical performances of these algorithms in the remaining 30% of the dataset, which is referred to as validation set. In particular, we evaluated the statistical performance of these algorithms by calculating specific parameters, including the area under the ROC curve, sensitivity, specificity, positive and negative predictive value, the F-score, and the Uden index. So thanks to our coding algorithms, we identified a total of 533 acromegaly cases, which were matched with 5,255 controls, and on these cohorts we applied our algorithms. So these are the performance metrics yielded by each of the proposed algorithms in both the training and the validation set. Maybe we can try to see that the random forest was the algorithm yielding the highest discriminatory power, as we can see from the value of the AUC in the validation set, and it was also the algorithm yielding the highest classification accuracy, as we can see from the value of the Uden index. The random forest was also the algorithm yielding the highest values of sensitivity and negative predictive value, and it identified a total of 38 potential predictors of acromegaly diagnosis. Having a look at the predictors selected by at least two different models, we observed that only the number of pharmacy claims related to immunosuppressant drug was the predictor selected by all the 5 tested models, while the other predictors selected by at least two different models included the request of free thyroxine level dosing, the number of pharmacy claims related to diuretics, agents acting on the renin-angiotensin system, antibacterials, and thyroid therapy, the presence of cardiomyopathy and diabetes as comorbidities, the request of specific diagnostic tests including a chest CT scan, cortisol level dosing, electrocardiogram, nuclear magnetic resonance imaging on facial structures, and lastly the presence of copayment exemption codes related to hypertension and permanent disability. Finally, to have a clinical interpretable classification rule, we decided to put all these predictors selected by at least two different models into an unconditional logistic regression model in order to build a metascore for the diagnosis of acromegaly. This algorithm yielded only an acceptable discriminatory power, as we can see from the AUC in the validation set, which was equal to 0.71, and it also yielded a low sensitivity of 40% and high specificity of 80%. And we found that the optimal threshold was equal to 0.08. This study has some strengths and some limitations. Concerning the strengths, we should acknowledge the large sample size, so we had the opportunity to work with more than 5 million patients, and this is particularly useful for the study of rare diseases in which the number of affected patients is very small. We should also acknowledge that we identified acromegaly cases in claims databases using a validated coding algorithm which yielded high diagnostic performances, and this has likely reduced the risk of misclassification in identifying acromegaly patients. As for the limitations, we should keep in mind that although machine learning models are a data-driven model which are able to identify novel predictor outcome relationships, these do not always translate into a causal relationship. And we should also keep in mind that Since we applied our algorithms on claims databases, this study has some limitations characteristic of this type of data sources. As such, the index date that we use to define the time frame for the diagnostic prediction may have been misclassified, so it is possible that our index date does not exactly coincide with the actual first date of the first diagnosis of acromegaly. In conclusion, findings of our study show that machine learning models are potentially useful tools for the early diagnosis of rare diseases, including acromegaly. We developed 5 different predictive models, and of them, only the random forest yielded an excellent discriminatory power according to the value of the AUC, and its performance was also better than that yielded by the Metascore developed by using the predictors selected by at least 2 different predictive models, while the others achieved only a poor diagnostic accuracy. To build such models, it is important to develop innovative approaches aimed at integrating the information coming from different types of data sources for the early diagnosis of rare diseases. And since in this field machine learning techniques are becoming increasingly important, it is important to invest not only in these tools, but also in the skills of the operators. Thank you for the attention.
Thank you, Salvatore. The floor is open for discussions. Don't know whether there are any discussions or questions.
Hello, thanks for the nice presentation. For your AUC curve that you had, you said there was a, thank you. You said that the optimal threshold was 0.08. It seems pretty low to me. And I think if you maybe change the threshold, you could have a better trade-off because your sensitivity is kind of low and your specificity is pretty high. I was wondering if you could comment, like, did you play with different thresholds? Was that the one that optimized the trade-off between the two?
Yes, we selected this threshold because it is the one who better balances the value of the sensitivity and specificity. So we keep.
And one other quick question. It seems like the best model was the random forest, right?
Yes.
That gave the best discriminatory power. I just wonder, you know, the thing I don't like about random forest is that it is a bit of a black box that you really don't know what's going on. It's just giving you an output. In terms of building an algorithm that you can apply externally, can you comment on how that would work with using a random forest?
Yes, thank you for your question. I mentioned in the limitations that one of the limitations of these models is that they are black box models. So this is why we decided to develop this Metascore to have a clinically interpretable classification rule. But we noticed that its performance was still not as good as that of the random forest. So,
but it wasn't too bad either. It's still really good. So thank you.
Thank you.
Good day. I also enjoyed the presentation. My name is Peter Mol. In the Netherlands at the University Medical Center Groningen. But I had a question on the impact, and perhaps I blame it then on the party yesterday evening, but I missed a little bit on how are you going to translate this to the impact, because this is claims data, as I understand.
Yes.
How do you feed that back to, okay, you identify patients with a rare disease earlier, could be helpful in clinical practice.
Yes.
What are the next steps, perhaps?
Thank you for your question. So the idea was to also using these algorithms for the development of digital tools that can be used both by general practitioners or payers for orienting the patients towards an early specialist visit by an endocrinologist, so with the aim of reducing the diagnostic delay of acromegaly, and so also provide better clinical outcomes for acromegaly patients.
Because you can't, obviously, from the claims data directly go back to the patient, I presume.
Yes,
Yeah.
yes.
Okay. Thanks.
Thank you.
I have perhaps a small question. Setting the index date right is an issue. You pointed out that yourself. I was also wondering, in your definition of acromegaly, you had 4 criteria, but like, for instance, imaging, that's quite not necessarily very specific. So I was wondering whether, 2 small questions there. So did they had to have one of these or a combination? And did you try to set the index date, for instance, a month sooner and test the model again?
Thank you for your question. So, acromegaly patients have to must have two
Okay.
codes.
Yeah.
So we internally validated this algorithm, and we almost achieved 100% of specificity and more than 80% of sensitivity. So we used both algorithms already published in the literature and ex novo algorithms created with the help of endocrinologists. So we do not try this to anticipate, but we can try.
Okay. Yeah. Thank you.
Thank you.
And for our final presentation this afternoon, Vikas Kumar will be speaking on severity score extraction from clinical notes using natural language processing with applications to dermatology.
Hi everyone, my name is Vik Kumar and I'm a data scientist at Omni Health. I'm going to talk about how we can use natural language processing to extract severity scores from clinical notes and how they apply to dermatology. These are my disclosures. So first, some background. Natural language processing can be defined as the analysis of free text data by a computer to get information and knowledge from that data. Question answering is an NLP subtask in which a model answers questions about a context. And you see an example of that here on this slide. On the left part of the slide, you see a paragraph of information, much like a reading comprehension portion of a standardized test. And what the model does is that you can ask questions about the paragraph and it'll return the answer. It's trained to find the portion of the text that corresponds to the answer. And nowadays, there's an abundance of large language models that are open source and available on platforms like Hugging Face that you can fine tune and further train for user-specific tasks. So what does this have to do with severity scores? Well, disease severity can be defined as the current state of seriousness for a medical condition. And disease severity comes in many different shapes and sizes. They can be divided into ordinal and continuous scores. An ordinal score is sort of like describing pain as mild, moderate, or severe. It's just a discrete scale and it can be represented by strings. Whereas a continuous score is represented by numbers, such as a pain visual analog scale from 0 to 10. Severity scores are important because they dictate how diseases are managed, and they're virtually a prerequisite for performing effective real-world data research. The problem is severity scores are not always available in structured electronic health record data, but they are often in the notes. However, extracting severity scores from notes is not a straightforward problem because, as I said before, severity scores are of different types. They're named differently. They're on different scales, and they're specific towards different diseases. So how do we extract all these different scores from using a single pipeline? You might say you could use a text classification model to train it on one severity score of one disease, but then you'd have to do that for every single severity score, and that would not be practical or scalable. So our goal was to use the disease-agnostic natural language processing question answering pipeline to extract disease severity for dermatologic diseases from EHR clinical notes, and to validate the pipeline by measuring accuracy of the extracted scores. So first I'm going to describe the data sources. For our study, we use the OmniHealth database. Basically how it works is that data suppliers send us data in the categories listed on the left, including the clinical notes. Once we have this data, we de-identify it, tokenize it, clean it, and normalize it to produce research-ready data sets by disease area. For this study, we use clinical notes from 2 integrated delivery networks and 5 specialty dermatology networks. So I mentioned in the example that we use question context pairs, and this is an example of how we form those. So you see on the left the name of the severity score, the corresponding diagnosis code, and then on the far right you see the context, which can be a sentence from a clinical note. And the first example says patient psoriasis is improved with a BSA of 40.0 in clinic today. So then we pair that with the question in the third column, what is the body surface area for psoriasis? And we feed it to the model, and the model returns a result. And I just wanted to walk through a little more detail of how we do our pipeline. So here's a sentence which is similar to the one I just read. So the first thing we do to eliminate false positives, we make sure that the patient has a diagnosis code for L40.9. And he does in this case. So we proceed to do the second check, which is to make sure that the sentence contains one of the severity score specific search strings, which in this case was BSA. And we see the sentence does contain the string BSA. So then we proceed to pair it with the question, what is a BSA? And we pass it to the model. The model, in this case, returned a result of 40 as a string. Some additional checking that we do is we check the range of the score to make sure it's appropriate for the severity score, and then we cast it to a floating point number. This helps us ensure that there's no PHI leakage in the final result. So here's a schematic diagram of the pipeline that I mentioned in the previous slide. Okay, so on to some results. So we had 448 million clinical note entries, and the entry is defined as a sentence or a paragraph, analyzed across 4 million patients and 16 million encounters. These were the results for the severity scores that were included in our analysis. So you see that we see that the body surface area did particularly well. You see it for a few diseases here, for psoriasis, atopic dermatitis, and bullous pemphigoid. We see accuracy of, in the ballpark of 70 or 80 or 90%. We see that some of the scores don't have that high numbers, and they might not be reported that much in the clinical notes, like the Fitzpatrick scale probably isn't reported that much. And not shown here are some scores that didn't have high accuracy, so they were not marked for inclusion in the final product. And those include things like the PGA, the Physician's Global Assessment for psoriasis, and the Hurley score for hidradenitis suppurativa. So here's our overall accuracy broken down by ordinal versus continuous scores. We presented a similar talk at ISPOR, and it was not geared towards dermatology. We had a higher accuracy, but unfortunately for the derm scores, we see that the accuracy is lower. It's like 56 to 52%, depending on the type of severity score, and the overall accuracy was 53%. And these are manually validated examples that we annotated after the pipeline. So we have some limitations and some future directions for improving these results. So obviously the pipeline accuracy needs to be improved for all the different severity scores before we can use this to do research. Also, the counts for some measures are low. So how can we capitalize on these results and improve them? One way is we want to independently annotate the notes before doing the pipeline so that we can measure precision and recall, not just accuracy. That way we can check how many are actually being picked up by our pipeline. We want to fine-tune the model for the severity score detection task using platforms like Hugging Face. You can do that. We want to add logic for detection of comparative phrases. For example, if there's a sentence in the note that says psoriasis is very good today, we want to be able to, that would not be picked up by our current pipeline, but it still contains information about the patient's psoriasis. So we want to be able to pick up phrases like that. We also want to add severity scores, run them on multiple sources, and we've done a lot of these things. We're just in the process of seeing how accurate the results are. And we also want to test for bias. That's an important thing to keep in mind with any natural language processing model is making sure that our results are not biased towards any demographic groups or severity groups. So on behalf of the team, I wanted to thank you for your attention, and please let me know if you have any questions. Thank you.
We are now open for discussion. So you have a specific application here for dermatology. You said that you've done this in other disease areas as well. I have two questions. One is, you said your objective was to make this disease agnostic. Like, how disease agnostic is this approach? And then I have another one after that.
Okay. I think it's fairly disease agnostic. It's not trained on a single disease. It's not trained on just one disease or one severity score. You can ask. The beauty of a question answering model is that you can ask it any question you want, and it can be trained to find the answer. So that's why I think it's pretty. You're right. I mean, it doesn't work for every severity score out there, but I think as opposed to like a text classification model, it's pretty agnostic.
Got it. And then have you thought about trying to predict the score from kind of everything else that's in the notes so that you can...
We've thought about that.
step?
I think that's a lot of groups do that. The problem with that is that it's just an estimate. It's a machine learning derived score. And also the scale is not preserved of the severity score, so it's hard to interpret. The voice of the physician might not be preserved. His exact words are not there. So those are some of the limitations, I think, of that approach.
I have two small questions.
Sure.
Because you say it's disease agnostic, but then I was thinking you're looking into severity score, but of course severity score, that's mainly going to be applied for instance, chronic conditions and not necessarily acute conditions. So I think that it's, I don't know how you think about it, but it might be by what you want to pick up from the data. It might be driven by the disease itself anyway. So, for instance, disease risk score for acute condition, I'm not aware of, for instance.
Yeah, that's definitely true. I mean, there are some, like pancreatitis has like the Ranson's criteria, but you're right. They're more common for chronic.
And then you had, I think, several data sources that you could use. I think when you mentioned a network, dermatology network, and then a delivery network. I'm wondering whether you repeated the analysis, but then looking whether some data sources had better performance compared to others.
Yeah, I think that might be one reason why that we got lower accuracy for the dermatology is because we have a lot of the dermatology notes are from the specialty networks.
Okay.
So it's sort of like a different data source.
Okay.
Hi, my name's Nancy. I'm at Biogen. In my experience, some of the NLP terms in other data sources have, instead of a quantitative value, they have worse or better. Have you incorporated that sort of thing?
We're in the process of doing that. I think, I talked about that in the future directions. Some of the people on our team did look at, phrases like within normal limits or doing better today and comparative phrases. It's hard to figure out how we can integrate that into like product, but we're working on something related to that. Yeah.
If there are no more questions, thank you very much.